Hi, everyone. Welcome to Perfusion Musings, the podcast from Envello Medical, where we're diving into the science of perfusion, oximetry, and the future of cardiovascular care. I'm Casey Boutwell, CEO here at Envello Medical.
And I'm Dan Rodenhaver. I'm the Chief Commercial Officer. And today we are joined by Dr. David Baran, who is the head of heart failure and transplant and mechanical circulatory support at Cleveland Clinic, Florida. He's also an advisor to Envello Medical and the first person to tell me what cardiogenic shock was. He's been a great friend of our company, and we've learned a lot. And we're happy to have you here with us today, Dr. Baran.
Thank you. A pleasure to be here, Ashley.
So, Dr. Baran, in addition to being a fellow for the American College of Cardiology and a fellow for the Heart Failure Society of America, you're also a fellow for the Society of Cardiovascular Angiography and Intervention, SCAI. And you played a key role, really, in the development of the SCAI shock classification system, which is now a global standard. Can you tell us a little more about what inspired its creation and how it's improved patient outcomes in cardiogenic shock management?
Sure. So, first and foremost, I'm a clinician. I take care of patients with shock and have been able to witness over the years of my career the evolution from when we didn't have a whole lot to now when we have a variety of devices and things. And actually, the idea for SCAI Shock was a very simple one. It came in 2018 when we were giving a symposium and talking about cardiogenic shock. And we realized that what I would consider to be severe shock or whatnot, before there was a way to describe it granularly, was somebody else's different. What I thought was the worst patient in the world, maybe, was somebody else's, not so bad, or vice versa. And so we would have these patients come over where they would be like, oh, this is so terrible, this is so sick. The patient would come over and like, really, this is not too hard, and realize that nobody had actually done the equivalent of an NYJ class for a shock. And so working with the team from SCAI, their interest was, they said, well, we have a lot of interventionalists, but we don't have people who really know how to characterize shock. And you come in and ask us to put devices and things in people. And we realized that maybe it would be right to invent a classification. And we really didn't know whether anybody would actually use it. I remember, we put together the group. SCAI thought, this is a clever idea. Fine, we'll put together a consensus group. Can't be a guideline because there's no data. But they said, if we want to put a group of people together and write something, we'll look at it. And so I was privileged to co-chair along with Hari Naidu. We had representation from intervention, from ICU, and a lot of the luminaries in the field like Cindy Grimes and Dan Burkhoff. And we published it not really knowing whether it would just be yet another paper on the field of manuscripts. But in fact, one of the colleagues I met at Mayo Clinic thought it was a really clever idea, Jake Jensen. He said, why don't we put together a paper and try and validate that? And he had a population of patients. And that was really the seminal finding, that we had somebody that quickly could put together 10,000 patients in a retrospective and then say, did it actually work? And so it was so simple and elegant, and it worked. That really started the ball rolling. It's been very gratifying to see that people have actually adopted it and used it in all fields of cardiogenic shock, all different kind of patient population. And for me, it's great because taking care of patients, doing something that in some way helps improve the outcomes, is very gratifying.
That's great. Yeah, I see it in many of the papers that we read. The SCAI shock pyramid comes up. I use it in many of my presentations, even to my team internally. One of the challenges, I think, in medical innovation is that you have to go about teaching this new modality not only to students but to existing practitioners. How are you helping to spread sort of the word about the SCAI shock staging for cardiogenic shock?
That's a great question. So, I think the key to it was designed to be quite simple. And I would say to people, that's the strength as well as the weakness. So I can teach somebody the classification in 5 minutes. This is just intuitively obvious. You're either at risk, you're at the beginning of shock, you're in the obvious shock where the patient's not well perfused. And then the key additional parts that we had were deterioration. The idea being that wherever you started, if you're not getting better, that's intuitively obvious to the clinician at every stage, whether that's the APP or the RN or the resident or the attending physician, you're deteriorating. And then extremis. Everybody can recognize the extremes. They can recognize the somewhat well patient who maybe has that risk but is doing fine. And everybody recognizes the E patient when you remind them this is the one where there's a code cart sitting at the door and people running around like crazy. The patient's in cardiovascular collapse. On the other hand, some people have sort of criticized and said, well, give me exact criteria. what lactate value is a C to D or whatnot, and point out to them that if it's very rigid, and some have tried to sort of adopt particular rules, the more complicated you make it, the less useful it becomes. People are not going to pull out an app as they're resuscitating somebody to try and figure out what is the sky stage. They intuitively just know. It's like the old quote of, you can detect obscenity, you know it when you see it. Some of the newer things that we're working on with Sky is trying to add the different perspectives of the different people who use the criteria. But I think it'll always remain fundamentally very simple, very usable.
Yeah. Well, you've done a great job teaching me.
So as you say, there's this has become a rating system that most people are using. But what do we do? So now we can identify it. But you've seen a lot of changes with how we treat shock. So what do we do with this information, and what advancements have you seen in that area?
It's a great question. So, what we need to do with it is to actually run trials and coordinate things based on the level of shock. If you look, for example, at the trials that have been done with ECMO, stage E patients, very, very sick, unfortunately, none of them have worked, whether that's the ECMO CS trial, the ECLS shock trial. And I go back to the analogy of fire, that if you have a Sky E patient, that's like a forest or a house that's on fire with flames coming out of the windows. No matter what you do, you're really shifting your goals from trying to put the fire out to sort of save what you can, but the house is going to burn down. It's pretty unlikely that you're going to reverse it. And interestingly, that's I think the utility in patients. It shows that some patients that are extremely ill, you might save some, but the overall mortality is so much higher. And it highlights that then, in fact, earlier degrees of shock, earlier degrees may actually be more amenable to treatment. And it also, I think, identifies that we need to identify the shock more quickly, right? Anybody can recognize the patient in shock when they have no urine output, they're cold, clammy on 4 pressors. Well, it's about 12 hours too late. And really sort of need to know when they were in earlier stages. And been a lot of people who publish on the transitions of Sky stage that really help. So at least now you have a way to classify shock that's simple by all the care partners in the team. Then you also realize that progression of shock is dangerous. Then no different than in your house. If there's a wastebasket fire, you don't go out to walk the cat or the dog. You put it out because it's a big priority. Why is it that we sort of say, oh, I had a big STEMI. Oh, they look okay. We opened the vessel. Yeah, the urine output's not so good, but we'll see how it goes overnight. Really? You wouldn't leave your wastebasket burning to just see if it spreads to the rest of the room. And I think that's the value of the shock, because we're really poor. Once the shock is out of control, nothing works. I think the only way we're going to get somewhere is by catching and maybe hopefully identifying shock at earlier ways.
And so how have you seen that progress? Like what are people working on? What are you seeing? What's useful for you and your institution to identify that, and protocols for your staff? How do you address that and find it earlier?
Yeah, so at the moment it's still fairly primitive. We use, for example, lactate measurements, but you have to remember that lactate in most places outside of the cath lab is not point of care. So if you have a patient you're worried about, you can ask the staff member to send lactates. You can follow the gases. You're already suspicious that something bad is happening, but it also strikes me that this is somewhat late, and it also requires the first element that you realize the patient's at risk. They're already probably a little bit far along by the time you realize maybe something's not so good. And the one that bites you in the butt is a patient you don't realize is that bad, and something starts happening. And usually by the end of the shift, then you realize, you put all those fats together, something's not right. And you hope you can sort of dig your way out, or these are the patients that look poor. You say, well, I'm bring them downstairs to do a right heart cath. You identify shock on the Swan-Ganz catheter, but you realize actually probably things weren't so hot 6 or 8 or 12 hours ago. Similarly, Sky is working on the idea of door to lactate clearance time. The idea being that more people should follow things like lactic acid or whatnot. But still, these things require blood draws, requires time, and the more complicated you make it, the more challenging it is to get widespread penetrance.
Yeah. No, those are all very real burdens to finding out in a timely way what's happening. What role do you think non-invasive devices play then in the management of cardiovascular disease, even just looking just within the hospital?
So non-invasive devices are many in the ICU. You have patients, for example, come in and staff has put in, one of these variety of devices that attaches to an A-line or a triple lumen or whatnot. Maybe the more enlightened ones will have placed a swan, and hopefully it's placed properly and zeroed properly, and they're trending mixed venous. Those are things we've had for many years. All of them require some level of invasiveness, which is that bar of entry. Every once, we get called for consults. I'm not quite sure what's wrong with the patient. And to my lens, as a heart failure expert, I could look and say, well, clearly this patient, looks to be poorly perfused, but not everybody necessarily make the same judgment. So, it would be ideal if you have a way to have a less invasive device that is able to monitor the status, the perfusion in some ways. You can always escalate to a Cadillac that has a Swan Gans with a continuous cardiac output monitoring, but arguably that's already a little bit late. You've already realized the patient's willing to take the risk to have an invasive catheter. You've already seen things that have made you concerned enough to do it. As getting it backwards, getting it before that point of view might be better. We don't really know what would happen if you could find shock at early stages.
Yeah.
So you're considering your experience with Sky and bringing that to the forefront of people's knowledge and experience. What about new technologies like this? What will it take for the community to sort of rally around a new prediction device like that?
I think, some would say that, gee, you need to show outcomes, but I think others would say more information is better, particularly the degree of difficulty, right? So Swan Gans catheters still remain a minority use, even though we've had them since the late 60s, because of the risk that you have to put the catheter in, you have to kind of hurt somebody with a pulmonary embolism, you have to have the skills to place it appropriately. And so people will debate and say, well, there's no clinical trial that proves a Swan is helpful, even though we all think it's a good idea. It's still only about 20-30% of patients get it. So I look to the future when the price of the device is just financial, but not patient risk related. I think that becomes something where people say, yeah, I'd love to have more information. And then you really look to see how many times does the device give you actionable information that changes the course. That you'll only know when you have such a device out. But I don't think it would be difficult to convince people to have another kind of sensor that would help them, particularly if it's something that doesn't involve really any particular risk of insertion.
This is great. Thank you very much for your guidance and spending some time with us today, Dr. Baran. You've been a great stakeholder and teacher for us to help understand how we can move these technologies to their greatest clinical impact. So thanks again for spending time with us today.
Happy to talk to you guys. Take care.